Welcome, welcome, welcome to this edition of I'm Not Crazy, but I am Dr. Rhonda Mattox, your host. I am so thrilled that you're able to join me today, and welcome to spring break season. I know it's almost over, and in the spirit of I'm not crazy, but I'm tired of waiting on my doc. I'm not crazy, but this doc is disrespecting me. We have put together an amazing episode entitled drum roll, drum roll, drum roll. When is it time to say goodbye to your doc? When is it time for a change? When is it time to let them go? Now, I will tell you, I have not had to do this much. I had one doc that I had to part ways with, and that was because I was exhausted with the 2 hour wait time in his very congested wait room. Today, I have some amazing guests, and we are going to talk about when it's time to pull the plug on the doctor patient relationship. As I begin to introduce these amazing guests, this all star cast that is here with me today, you know what to do. Begin to drop your name in the chat and your city, rep your city. So now we have, of course, the man who needs no introduction with us, and that is one of our favorites, our producer and a former counselor in another life, and that is the Mr. Ellis Dean. And then we have a dear, dear colleague that resides in Savannah, Georgia, who parted ways with traditional medicine as we know it, and that is family medicine doc extraordinaire, Dr. Ashley Booth. Thank you all for joining us, and I'm so glad you're here today. How are you doing?
We are
I,
great, and Dr. Aaron Briggs, another regular on the show, has popped
yes.
in right as you were doing your introduction. So we have we've got a dream
Have
team
an
here today.
all-star cast. Dr. Griggs is a man who needs no introduction. He has his own show. He is the ambassador, health ambassador in New Orleans, and is a community activist and a community physician. Thank you so much for joining us. We're so appreciative to have you, Dr. Griggs. So,
Thank
in
you.
the yes, yes, yes. How are you all surviving spring break season? You're surviving? Yes. Yes, yes, yes. Now, for those of you who are just joining us, we are talking about when it is time for a change, when it's time to part ways. Now, some of my patients, as a psychiatrist, I hear a lot about from disgruntled patients who are disgruntled with their family medicine docs about and wanting me to prescribe their medicines. And I tell them all the time, darling, you don't want your psychiatrist prescribing your cardiology meds. You don't want your psychiatrist prescribing your headache meds. You want to be with the people who have expertise in that area. But a part of the reason why they want me to do that is because I listen. So before we jump in and get really, really started, I want to ask the question that I'm sure our audience is asking. Have any of you ever had to part ways with your docs and and or know someone, wink wink, who parted ways, know someone that you're very close to who parted ways? And what were your reasons for parting with your docs, if you're comfortable sharing?
So I can say that I parted ways with the entire institution of the traditional medicine system for the reason that a lot of people list. I finished in '96, did a transitional residency in community medicine for a year. And that's when things were starting to be in flux. As a medical student, if y'all can remember, would be given up to an hour, hour and a half to get to know our patients. As you progress, I was first and second year, third year, it was like 45 minutes to an hour. Then you go to, by the time you finish as a fourth year and as a resident intern, you get about 30 to 45 minutes to go over particularly your more complicated patients. Well, that changed. The average doctor visit these days now is about 12 minutes with 6 to 7 minutes of patient doctor interaction. I didn't feel as though that was enough time to get to know my patients, and I definitely didn't feel like it was enough time to educate people to get better. If I see you once a year, I can't know what you've done in 12, 15 minutes. So that once that time started condensing, that's when I started looking into other things that I could do in the medical system, like clinical research. And now it's a lot of public health, health communication, health advocacy, health education. education piece. A lot of people complain about feeling rushed these days.
Oh, those are great points, Dr. Griggs. And I will tell you, that is probably one of the primary complaints that I hear from patients. There's not enough time. Back when I was coming through, people would spend time with their dogs. They talk about their kids, they talk about their families, and now that whole 7 to 10 minutes, and sometimes that's if you're lucky, can really be a challenge to get out everything that you need. So I like that you said you actually decided that that way of doing medicine was not right for you and pivoted. Anyone else want to weigh in? And it's okay if you don't.
I'll chime in and kind of piggyback off of Dr. Griggs because I noticed the same thing. I actually started to feel the pinch in residency. When we first started my first year, I had an hour with my patients. I was like, this is lovely. I love this. And then as time progressed, they were like, okay, now we need to shrink that down to about 15 minutes. And I said, well, it takes me, I'm a talker. So it's going to take me a little longer just to say hello, essentially. And so I really wanted to get to know my patients. And I was like, you've got to be kidding me. I went through all of this training, and I have such a love for people and getting to know them because that is a huge component of medicine. If we're honest, medicine is not just, treatment. It's also you have to get to know the person to see what treatment they're going to need so that they can be on board and have this relationship where they trust you. In 5 minutes, it's really difficult to establish that trust. So I too decided to kind of disengage with what we look at now as traditional medicine and went back to kind of the old school way of doing things because I have a lot of my older patients that say, I remember when the doctor used to come to your house, and I remember when the doctor used to know your name, and I remember when the doctor used to sit with you. I was like, isn't that lovely? That does sound really nice. I said, how am I able to do this too? And I decided to kind of break away from what we do now and do what they call direct primary care because my patients and myself were getting frustrated. They have those long office waits that you talked about in the beginning, Dr. Rhonda, where you're sitting there for 2 and 3 hours. And then you come in and it's like for 5 or 10 minutes. And it's like, wait, I waited all that time. I have more things I need to talk about. And from a patient side, I can see how it's frustrating, but also from the physician side, I was frustrated and rushed and having to see my patients that way. So that was one of my reasons to kind of disengage because I was feeling it, but my patients were also experiencing it as well.
That is a really good point because when you're talking to it's great to hear it from the physician side because when you're talking to the patients, they tend to think that the physicians are being knuckleheads and that we don't want to spend time with them. But as I'm listening to you, and of course via my experience, what we are experiencing on the other side is that we have people who are not physicians running the systems who are saying you need to see 4 to 7 or however many people in this hour. And I know for me, I have to personally negotiate as I'm going into a job that I want to spend 30 minutes to an hour with the patient. And believe it or not, that actually is a negotiation. And I've had people say, as a psychiatrist, can you see 4 to 6 people in an hour? And that then I realized we don't have the same values and this is not a good fit, and it's a wrap. So patients, people who are audiences, you're listening, please drop in the chat why you have chosen to leave certain doctor's offices if you've made the decision. So what I've heard so far is from Dr. Griggs and Dr. Booth, you both value time with the patient, recognize that it is something that you need, and not just for a diagnostic sake, but for patient satisfaction as well. Ellis, do you want to add anything before we move on?
Sure. I think I handled on the patient side. I think I handled it more like you did when you were dating when you were younger. I just did the no call breakup, right? So I'm just not gonna call you no
You ghosted him.
more. So there it is. That's the word. I would just ghost them. I'm like, I'm not trying to see this person anymore. So why am I? They'll figure it out once I stop calling. So stop going to see them and go see somebody else. Especially they'll know it when they get that request from my medical records being shipped to somebody else's office. They'll really figure it out then. So I think all jokes aside, I think that's how a lot of patients tend to do it.
Hmm.
Patients who just disappear from practice and you don't understand why. Um, it probably is more respectful to let the physician know. And Colleen, that's watching, she left a comment and said she left a doctor who wasn't willing to change a medication that had side effects that worried her. And so that is a more real reason to leave a doctor. And that's really what I think the crux of this argument is, of this discussion is today, is to talk about what are some of those things that can transpire that would be a good reason to leave a doctor. And I think she points out a very, very specific one that says, look, if you're prescribing me a medication and I'm reporting back to you that I'm worried about these side effects, and you continue to prescribe me that medication, that means you're not listening to me, and
Hmm.
that I can't trust you to do what's best for me when I'm reporting back to you something that I'm concerned about as your patient. And so, and there, that's a communication issue, that's a trust issue, and you need to leave it as quickly as possible.
Absolutely.
So,
Absolutely. Some of the reasons, I'm sorry, Ellis, go ahead and finish your thought.
Oh, I was
but
done.
no, that was actually me, Dr. Maddox. I just wanted to add in. I want to make the tie there because that a lot of times, Colleen, that actually goes hand in hand with what we were just talking about. Those doctors might not have the time to explain and to have the conversation about your side effects because again if you're on a clock you have to see a certain number of patients. So I think a lot of times you need to dig a little deeper, saying that you don't have time to see me or you won't take time to explain this to me. And it's two different things. And a lot of times that, between, I guess, what you have to see the patient, you have to listen to the patient, but then you have to type what is the EMR system now, and it's monitored and charted. You have to, and then you're worried about HEDIS measures and looking at the labs, and the patients are usually booked back to back to back to back. And I'm not making an excuse for any poor behavior, but I want to probe because if there are questions that you have, like I don't want to take this medication until we have a further conversation. Do you have someone I can speak to outside of yourself and or the pharmacist? And if before you go to the doctor, stop at the pharmacist window, at that little window that everybody cheats to skip the line, little consultation window. Pharmacists love to talk to people. So talk to them about side effects and go in with your targeted list. And if they won't talk to you or take the time to explain your bulleted list, that's when I think you can make a more educated decisions as opposed to just emotional, because I can see how that could be emotional.
And one of the things, so there's some very legitimate reasons. Certainly, you don't feel like your doctor is listening to you if they are giving you medicine and you're talking to them about side effects. Some other reasons that people tend to leave is just that they age out. From if you are no longer, if you're seeing a pediatrician and you're no longer, and you're 18 to 21, then you transition to um, family medicine doc, or if you are seeing a family medicine doc and perhaps you hit your mid 60s and you want to be seen by a geriatrician, that's those are reasons to leave. But the reasons that I hear of frequently are poor bedside manner, don't care, stay in the waiting room entirely too long, um, feel like the person is disrespectful of them and not listening. I've had people who came in and they definitely wanted Xanax, and I wasn't giving it to them. Atop of their marijuana and their alcohol, and so there are times when you have certain cocktails that you want, and physicians aren't willing to abide by that. What are some additional reasons that are um, and here's the thing, we say good reasons to leave. Whatever reason you choose to leave is a good enough reason for you to leave. But what are some strategies that you can use um, to champion for yourself that might allow you to remain if you think the relationship is worth fighting for? Because sometimes you've had a really strong relationship with your doc for years, and then there is a thing or two, and maybe you're trying to decide, do I stay or do I go? What are some reasons to what are some good reasons to leave, but what are some reasons to consider having a conversation with your doctor and not ghosting
Mhm.
them?
I think
So
that's good, Dr. Rhonda. I think one of the things that people have to think about are their needs. Because as you get older, your needs may change, or as you go through different seasons, your needs may change. And sometimes that doctor's needs and yours may not align. So you have to figure out kind of where you are there. But I think that's the first thing that you have to be able to figure out, because some people are saying, okay, I'm okay with the 2 hour wait, but when I get back there, are you going to spend enough time with me to really, I feel like they actually spend enough time with me. For me, at this stage of my life, I can't wait 2 hours in your waiting room. I'm sorry, that is just not where I am in my life right now. So you may be a great practitioner and you may spend a decent amount of time with me when I get back there. But right now, a deal breaker for me is spending so much time waiting to come see you. So I think you have to evaluate kind of where your needs are and first get that understanding. And then once you figure out that, then you can figure out, okay, is this something that I'm going to be able to get from the doctor? So if you know that you have a short period of time, what I tell people to do, especially those who are still in the system and have that 15-minute visit, which is really only like 6 minutes, I tell them you're going to have to figure out how to advocate for yourself. And the best way to do that, the first thing you have to do is you have to be prepared. I have patients who come to me and my visits are much longer. My visits are 30 minutes to 60 minutes. And some of them still kind of like, oh, where did I go? I don't remember this and that. I'm like, no, okay, come on. Let's be efficient with our hour though. Let's be efficient with our 30 minutes. When you have 15 minutes and realistically only sit with a provider, you can't do that. They do not have time for you to look in your phone to figure out, did you go this place? Did you go to that place? What was the name of that medicine? Oh, it started with the M. Oh, it was a purple pill. Oh, maybe it was white. Oh, it was little. Like all of these things, they don't, there's just not enough time. So you have to be prepared. And by being prepared, the first thing too I tell them is know your concerns. You have to know. Like I literally have some people who come and they say, I had something else to tell you, but I can't remember what it was. And I was like, okay, I can't sit here and wait forever to figure out what that was. And then you leave and then you try to call that office back and talk to them, and you are not going to get that person. I'm sorry. That's just not how it's going to go. So you have to know your concerns. You have to be specific about those concerns and say, this is what happened. This is when it happened. I've taken this specific medication. If there's some over the counter medications that you have taken, let them know. There are a million Mucinex on the counter now. Like Mucinex has all these different types. So if you're taking something like that, know which Mucinex. And this is the greatest tip that I tell everybody. Take a picture of it. First of all, when you want to be prepared and you have your concerns, pull up that little you have a notepad in your phone, write those concerns in there. Put it in there, and the other thing to put in your phone are those medications. Take a picture of it. So then that way you'll know the doctor will be able to look at it and say, oh, okay, you're taking Mucinex DM, you're taking Mucinex so and so. So this has this medication in it along with it. So now I know what I should give you, what I shouldn't give you, if you should continue it, if you should stop. It gives us a whole lot more information. So once you're able to do those sorts of things, it helps us help you. So once you're thinking about, is this relationship worth salvaging, then start thinking about what you can do to help us help you.
I love it. So, some of the takeaways are, make sure that you know the exact name of the medication. If you need to take a picture, if you need to call the pharmacy beforehand, do that, because trust us, when you say that green pill that's triangle shaped, we don't know what you're talking about. And the other piece is to write a list for what you want to talk about. And we don't want you to think that we are blaming you and saying you're the reason for it, but these are some things that can take the appointment, can derail it, because truly there are, I've heard about some egregious things that
Oh,
happened in appointments, personally have heard those things, as well as heard, witnessed some things of people perhaps making fun of doctors, particularly. I've heard a lot about fat shaming and those kinds of things. Ellis or Dr. Griggs, any of you want to weigh in on what Dr. Booth said?
Yeah, I think particularly there's some great comments that are coming in. So thank you, Francesca, Costello, Colleen, Ramona, Tina. Tina, you're a regular watching this program, so thank you. Um, from what I'm reading in the comments, it really kind of boils down to what Dr. Griggs and Dr. Booth were talking about in terms of that relationship, right? And so what physicians are faced with today are an inability to be able to create that relationship bond that you need, particularly with when you're dealing with patients of color, because we walk into that space with a natural distrust of
Mm-hmm.
healthcare and of the system itself. And
Mm-hmm.
so when I'm walking in there with the distrust, with my arms folded, with an expectation of not being treated or not being seen, which is one of the words that was put in a comment,
Mm-hmm.
um, and then that becomes validated. So you're looking for affirmation and of that belief when you walk in. And so that shortness that is really driven by managed care and that 12 to 15 minutes,
Mm-hmm.
that shortness that they're getting, they're perceiving that as, oh, this doctor doesn't really care about me. They don't really see me. They don't want to be in this room with me, blah, blah, blah. And that's really that doctor feeling that pressure of I've got 12 minutes to be with you, 3 minutes to write this up, and then to get into the next patient because I have to see 4 to 6 this hour. So it really is the context that they bring, that both people are bringing to that room that could be causing some of that mistrust or distrust between the two of you and miscommunication. Now the reality is, as Costello mentioned, that there could be something else bigger. And that particular instance was they felt like their cardiologist didn't care about them after they were discharged from the hospital. Went to see him the next day, and he said I had a strong heart, but ended back in the hospital with another heart attack. So that is a very real situation where your doctor is not really attuned to what you're doing. And so the trick for patients like myself, we have to try to navigate that when we don't really understand medicine or healthcare, right? And so we're leaning upon the expertise of that person to keep us safe, healthy, and alive. And then when that fails, that's going to cause a significant amount of distrust, more distrust in the system. And so so I think it's incumbent upon healthcare professionals to recognize that when people come to them, see them, when they walk into their office, they are literally, in some cases, putting their life in your hands.
Absolutely.
Respect them for that. Honor
Absolutely.
them for that by giving them your best, no matter what managed care says. I need you to respect, see, and honor the fact that I'm putting my life in your hands in this moment.
Absolutely. Are there any strategies that you would share with our listeners for what to do beforehand? Some people will just leave and not go back. I certainly have been guilty of that, but many times you'll need your doctor's records or something like that. What Let's see here. I use my chart, which is a very effective tool for taking control of your medical information, and you usually get a fast response from your doctor. That is a great strategy, Miss Lay. I like that, using your chart, your digital chart is really important. Back to my question, are there any strategies that you would recommend for people to use before they leave? Are there any conversations, any strategic conversations that should happen? And I say this because sometimes we can leave a family medicine doc, right? But there are other doctors that are more specialized that you may feel more pained leaving, an endocrinologist
Mm.
that is perhaps rare in your area, an orthopedic surgeon or something like that. And so sometimes you can just jump ship and leave, but there are other times when, based on the specialty or your particular situation, where you don't feel like you have um, that is the best option for you. What do you tell patients to do during those times?
So I'm sure Ellis is looking at me
Right?
now, wondering why I'm so quiet because I
I'm
have a
looking at you
totally,
now, wondering why you're
yeah,
so quiet.
Yeah, I have a different perspective on all of this. I mean, those strategies that Dr. Boot talked about are obviously ones. Be prepared before you go in, Ellis. Ellis brought up something. I have a very different perspective. I think that you should treat both doctor and patient should treat this like a relationship. If someone disrespects you to the point that you feel you want to leave, bounce, peace out. They don't deserve it. They don't deserve, just like if someone is rude to you on a date and you get up, say, I'm going to the bathroom, and you get in your car and go home. I know of numerous instances where patients are disrespected if the values don't align. The relationship between a doctor and the patient is one of the most sacred and intimate relationships on the planet. And it wasn't until the last 3 years that we've seen us be more vilified than ever. People trusted doctors with their most intimate secrets to keep from their spouses, to keep from their families, their brothers, their sisters, and we are sworn to secrecy. It was only when that we were vilified and medicine and healthcare was overly politicized that this distrust, conspiracy theories, and all that were able to weave their way in, even amongst doctors in our community taking care of our community. So I go back to what Ellis said. The common thread in everything that everyone's saying is trust, 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 trust. Trust your gut. If you don't, I don't care if you have a specialist doctor. If you have a specialist doctor that treats you like a piece of meat and a patient instead of a person, there's another specialist. They're cranking out new specialists every year. You can keep finding a doctor that will meet your medical need. Now, I'm not advocating for doctor shopping or drug shopping, but you can treat it like you would a relationship. Like you would, Ellis said, he'll just bounce. There are doctors that you give grace for. You know what? She's going to show up late. I know she's really, really busy, and I don't mind waiting because I enjoy the experience. There's a connection. You should try to get that connection, and you have to do every bit of your part. Like Dr. Booth said, if you know you only have 6 to 7 minutes, and for you to do your part, you have to do your work to maximize it because you feel good and you trust that this doctor has your best interest at heart, especially if she knows she has 6 to 7 minutes, but there's something really wrong, and she sits down and is like, wait a minute, before we do any of this, are you okay? Let's talk for a minute. Listen, I'll be here late. But I need to know, are you important? You have to, if you want that same respect as a patient, your job is to be honest. Your job is to hold that doctor's foot to the fire, but it's also to be compliant. And most importantly, we're on blackdoctor.org. We have resources. If you don't understand something, I don't know what you mean. Hypertension, how does that affect my kidneys? I don't understand. And explain it. Look for other resources to have it's a mutually respectful dialogue if you've done your part and they've done their part. So all the stuff Ellis said, yeah, I agree. Yeah, all that Dr. Booth, yeah. But no, if you don't like the way you feel, if they make you feel bad, bounce. There are some doctors that have biases that walk into the room and keep those biases. They've never been more prevalent than in the last 3 years. If someone's bringing politics into your doctor visit and you don't want it there, maybe you should consider, after you ask him to redirect, he or she to redirect, they don't do it, bounce. And get your chart and bounce. The respectful thing to do is go through all the proper channels, but I'm sorry, like you wanted me to talk. I'm just saying, it's a relationship. You have to do your part, but you hold their foot to the fire to do their part like you would in a relationship.
No, and I absolutely agree with Dr. Griggs on that one. Now, there's a few things like people do, but like it's totally just like you said, and it has to be a mutual respect and it has to be trust, because I take it as an honor every time someone steps into my office, because for a fact it took a lot for me to get here. So a lot of people, I don't like doctor, I don't do nothing. But then go to the doctor. So for you to actually show up and sit there, there's some level of trust that you're starting to give me. I have to be able to build that relationship with you to see, okay, how can I help you solve the problem or this issue that you're having. So it definitely has to go both ways. If you feel like someone is being totally dismissive, totally not there for you, and you can feel it. You have the vibes like him. It is a relationship. If you're not getting that and you feel disrespected, you can go. Like I have some moments in my life, like if someone disrespects me or whatever, I'll tell them, hey, don't do that. And then sometimes I get down. I'm like, okay, I've said what I said, and now I'm moving on. You have been blocked. I don't call you. I don't do the things. But you have to do to protect yourself, because it is you, it's your body. This is what you have to deal with. And you have to trust that they are going to do what they said that they are going to do and take care of you. So if you are not having that kind of relationship, he's right. You absolutely have to find that person, your person who's going to do the thing for you.
I'm gonna play a little bit of devil's advocate on this one, and also kind of following along the relationship theme that we established from the from the beginning. And number one, to Dr. Griggs' point, yeah, if somebody's disrespecting you in a relationship, you bounce, right? You don't hang around in that. But also in a relationship, you've got to bring what you need to the table, right? And so if you're not giving 100%, if you're not giving, and then you expect that person to not only do what they're supposed to do, but then anticipate what you want and what you need without you saying it out of your mouth, then how much of that is on the person, right?
Mm.
And so we have to recognize that as patients. And I love that's why with Dr. Booth, you're giving us tips. I was putting them on screen. You have to be prepared. You have to know the medications. You have to be honest with what you're doing. So if it says recreational drug use and you know you recreational using drugs, you
You
need to
high right now. You are high right now.
you need to say that. You need to
I
say
smell
that
it.
out loud. So those things are the bare minimum that you have to bring to that relationship.
Mhm.
And by doing that, I promise you, just like in a relationship, if you do what you need to do to make sure that relationship is going to be one that has good communication, one that is trustworthy, one that you respect and that you both lean in, you have to do your part as the patient. And so you can't just expect the doctor to do and know everything when it comes to that. And so some of it is on us, right? And so I'm going to like you do in a relationship. I own what I own, so I'm going to own what we own as
Mhm.
patients. To say, okay, you can't just walk in and expect this person to read your mind, know what's going on. You tell them that it's a triangle green pill, and they're supposed to know what that is. And like, no, no, I was doing it. I don't know how long ago that was. I went to my checkup a couple of weeks ago, and it was something that I didn't remember. I asked the question. I said, what was the name of that procedure I had done? And they told me, and he said, oh, and what year was that
Mm.
again? And they told me what year it was. And I said, okay, cool. I just need to know. So going forward, if I get asked this, I can put down everything that I've done. And they're like, oh, yeah, that's great. That's how you build a relationship. Open up your mouth, say what you need, and but be prepared when you walk in that door. And yes, full disclosure, I was late for that appointment. But I didn't walk in demanding to, to see the doctor. Look, we keep it 100 on this show. What I walked in was I knew I was late. I said, I apologize for being late, and I will understand if the doctor cannot see
Mm.
me. I understand, I said, I understand that, but if she can see me, I'll be here. Let me know, what you decide. And then they went
That's
back and you talked to her, and they were able to see me. But you can't walk in with your attitude on when you're 20, 30 minutes late. Like,
mhm.
that don't
Yeah.
work. That don't go together. Come on, people.
Talk about it. Talk about it. I love it. And I we have some great comments in the chat, and I don't want to miss them. Costello Carson says sometimes you can shop around for a different doc, but your insurance won't cover your care. It seems like
Mm.
insurance companies control your care. Someone else asked this question. I want to make sure that we answer it. How do
Yeah,
you?
Colleen asked the question. She said, "How do you find a doctor that isn't part of the managed care system that my insurance will pay?" And so, yeah,
Mm.
sometimes you are held hostage by insurance.
And so let's talk about that. Someone else asked about direct primary care. Ramona Rogers says she's willing to have direct primary care so she can be treated like an individual and not a number being placed in a category due to being healthy thus far. So let's talk about how to navigate insurance demands and direct primary care. And Dr. Booth, I'll start with you because you're one of the people who were doing direct primary care on this line.
I am. So with direct primary care, again, one of the reasons why I transition is because I want to treat the patient. We call it direct primary care, but a lot of doctors who are practicing this way are now also even calling it direct patient care because we work for the patient. This is one of the things, and I talk about it, and I did a whole live video on it about insurance because one of the things is a lot of times when we think about insurance, we think that it is going to provide us health care, right? Like we get it, we pay for it every month because we say it's supposed to provide me health care. It can, but maybe not necessarily primary care, because what we're seeing in the primary care system is all of these demands that they're putting on the primary care docs, and that's why your visits are much longer, much shorter. Like they're like those 15 minutes, and everybody's getting frustrated because it's like, okay, I can't get all of my concerns addressed in that time, things like that. And what we've noticed is that some docs are like, well, I will love to see my patients for a longer period of time because they don't want to feel rushed either. And insurance is pushing back and say, okay, you can do that, but we're not paying you for that. We're not going to cover that. So then both the physician and the patient are in a bind. And so that's when you have those moments when the doctor says, okay, unfortunately, I'm gonna have to bring you back for that. And when they bring you back, bringing you back is not probably a couple of weeks. It's probably a few months from now. You're like, but I got this problem today. And they're like, yeah, but I got to check all these boxes because your insurance is there. Because insurance is a contract. Every doctor who accepts insurance has to sign a contract that says, I will do X, Y, and Z for your members. And so you technically, as a physician, you are working for the insurance company because they have terms that they said that you must meet in order to serve their clients, which would be your patients. So once you start looking at those terms, everybody don't look at all those terms. I promise you, people just sign the paperwork and move on. But once you start practicing, you realize, oh, I can't do that. This is not covered. This is not covered. This is whatever. So you start seeing all of those roadblocks, all of those issues. And so I decided, I said, okay, I want to work for the patient. I want to make sure that they get exactly what they need. And so with direct primary care, the whole premise is we do not process or do anything with your insurance. We still think you should have it because I'm not crazy. I have insurance. I'm not crazy. I have it though, realistically thinking that it is going to cover me for catastrophic things. If I have to go to the hospital, insurance, I want you to pay for that. I want you to pay for my hospital stay. I want to go bankrupt because I had to go to the hospital for a couple of days. Like I know of someone who went for just a few hours, had a minor fender bender, but they did this full workup. They walked with a $30,000 bill in
Mm.
ER. I said, wait, did you stay overnight? Did you stay for a couple of days? They said no. And I said, well, where was your insurance and all of this? Did you have insurance? Yes. But insurance only paid so much. And so then that's how they ended up. And I was like, that's crazy. But I don't want to go bankrupt from that. So if I know that this is one of the reasons why I have it. But when it comes to primary care and some of the other things, then that may not be the best thing for me. So for me personally, the reason why I went to direct primary care is so I don't have those restrictions. I got so tired of telling the patient, I'm sorry, but we'll have to talk about that next time. Like it's one of those things like what Dr. Griggs said. I could walk into a patient and I could see that they came in for maybe high blood pressure, but I could tell by the way they're sitting that something is off. I was like, this is going to be more than high blood pressure today. So I would sit down and say, okay, what's going on? Like, what is really troubling you? So then I have to spend my time talking about that. But you know what else I have to still do? I still have to talk about that high blood pressure because that's what they came in there for. So I still have to take care of that. And I realized the time was getting shorter and shorter. So now what I'm able to do, the first thing that I do is access. A lot of people say, I call that doctor's office and they tell me, and I literally did this too, because I was like, let me see, because people in the streets are talking. So you got to check to see if the streets are right. So I called the doctor's office and I said, let me see. So they said, and I'm calling as a physician, so I know they put a little respect on my name, so I really get a chance to go up the ladder, right? I called them and they said, well, leave a message and don't pretty much don't call us back again now. We'll call you back in 72 hours. I was like, wait, but I'm a doctor's office. Like I thought y'all would I'm calling because I have a concern for a patient. So if they're doing that to me as a physician, what is happening to patients? And so when patients are telling me, they say, leave a message, and then they tell us, we will not call you back for up to 72 hours. We will return your call. What if your call is like, okay, I'm sick today. I want to make an appointment today. Well, if you catch that recording, that's usually what's going to happen. So access, patients have direct access to me. They can call us, but they can also text me. So that works very well because in this day and age, technology is great. We have a lot of things at our fingertips. So I text patients a lot because a lot of things are quick. They're like, hey, I'm taking this. Is this okay? Sure, that's fine. I have high blood pressure. It's okay because I got a little cold, but I know I don't need an antibiotic right now. Is it okay if I take this over the counter medicine? I'm like, actually, take this one. Okay, thanks, doc. Like very quick stuff, but because I have a relationship with them, they're able to get their concerns answered a lot quickly. So they have that access: phone, text
Hold on
message,
a second. So,
email,
Dr. Booth,
video
wait.
chat, the video
Dr. Booth.
visit. Yeah.
So, what you're saying now is they can get to you quicker, that they can get to
Hmm.
you directly. They don't have to go through
Hmm.
72-hour wait. They can text you. So with direct primary care, it's access, it's rapid, it's direct to the doctor perhaps, or to someone who is going to treat their needs as urgent or of concern quickly. Is that what I heard you say?
That's that. Yes, and that's just access. I hadn't even got to the other part.
Okay.
So the other thing, but the other thing too is relationship. My big thing is forming relationships with my patients. Like I really do want to sit down. I want to get to know you. I want to know what you do for a living. What are your hobbies? Who's your family? I went into family medicine for a reason because I want to know about your family, because I understand that all of those things play a part in whatever else happens along the way. So if you come in and you have high blood pressure and you work, depending on the type of work, like I have a few patients that are truck drivers, I might give you a diuretic that makes sense for your lifestyle. It may be a great drug to treat you with and to bring your high blood pressure down, but if I know that you take that medicine, you always have to stop. That means that you're likely not going to take that medicine. Is it a good medicine for you? So by
So hold
having those relationships, getting to know my patients, go ahead.
okay. So
Did you have a question,
hey,
Dr. Rhonda?
yeah. Have you all ever heard of direct primary care? Put yes or no in there and continue on, Dr. Booth. Direct primary
Sure.
care. Have you heard
So
about it?
with that, direct primary care, exactly. So what I do is I create personalized, customized treatment plans for my patients because one size does not fit all, and that's where the art of medicine come in. Now, it's still evidence-based medicine. I'm not out here going rogue and just prescribing any and all kinds of things, but I know, okay, I have these things. We have options, just like that one person chimed in and they said, this doctor still wanted to prescribe this, but I was concerned because of the side effects. The first thing that came to my mind is that, okay, we have options. That is not typically the only medicine. Now, if it's a super brand new in its class, then it's like, oh, well, maybe. But for the most part, we have a lot of options. And so if this one doesn't work, then this is the next one we can go to. So being able to be able to sit down and discuss your concerns. The other thing I've noticed is that when those doctors have those 6 minutes, they are trying to do the best that they can. Seriously, they really are. But they don't have the time to explain. And that's the piece that falls apart and causes people not to do what they're supposed to do. I've had several patients come to me and they say, this is what's going on. The first thing I come up with a treatment plan and I said, well, I'm going to get your records from your old doctor, but this is what we're going to do and this is why. And they're like, oh, okay. And they'll follow it. I get the records from their old doctor. I review those records and I see that our treatment plan is pretty much the same.
All right.
But the reason why they didn't follow someone else's plan is because they didn't trust it, because someone didn't explain the side effects. Someone didn't explain this is what can happen, this may happen, and this is what may not happen, like whatever. But they didn't have
But
the
we're talking
explanation.
communication now. You give them
Yes,
the communication allows you to build trust as well. So access, timeliness, trust,
absolutely.
length of time to hear from them and to hear from you. I like it. Anybody else want to jump in and add anything?
Yeah.
Did we have any yeses in the direct primary care?
Um, didn't get any yeses, but I would say this for our audience that's watching, and I would say this is that insurance is their primary goal is to make money, not to keep you well, right? And so you have to recognize that that's what it is. Now their job is to save you money, but they want you to be as healthy as possible. That's going to cost them the least amount because that's how they make money. They are a business operating from that model. So what you have to do is, as what Dr. Booth is saying, is leverage that insurance, have it there
Mhm.
for the big stuff. If something happens, you God forbid, you develop cancer or in an accident or something where you have to have an extended stay in the hospital, that you don't go bankrupt, because the number one reason people go bankrupt in this country is because of medical bills, not for any other reason.
Mhm.
The other thing is this: if your insurance has an HSA card component,
Yes.
leverage that as much as possible. You can
Mhm.
pay your prescriptions with it. You can use doctors and offices that aren't covered by your insurance. If they take a Visa, they could take that HSA card, and then now you can expand. That's what I do. You can expand your medical care because of that HSA card. So I've
Mhm.
used it to pay for chiropractic appointments, massage appointments. I paid for uh, other consultation when I needed to go outside of my insurance, because they said, well, we don't take insurance. I said, well, do you take HSA? They said, yes. I said, well, then I'm coming to your practice, right? And it is that simple. So use that HSA as a stopgap to where it doesn't hit your pockets directly, because you're already paying, you put money in it by having the insurance. So use that HSA. Operate your health as if you would your finances, right? You've got to watch over it, you've got to maintain it, and you got to make sure that it grows, right? And so if you're going to do that, then you've got to use insurance for what it's there for, not to cover you, but just, hey, as a crutch, leverage that HSA card and
Mhm.
give doctors the same grace that you want them to give you when you walk in the door.
And I will say one thing, Dr. Booth, the people that I traditionally refer to direct primary care are people who see physicians a lot, because I was really surprised at how affordable it is.
Yeah.
And and I'm a person who will pay for convenience, and so the convenience of it and the affordability was striking to me. But I send a lot of people who are aged, who have cardiologists, urologists, and a whole bunch of people in the mix, because if you have too many cooks in the kitchen, stuff is salty, real salty, and it doesn't taste good. So
Right.
I send a lot of people who are either have a lot of docs, or people who need convenience because of their schedules. But certainly people who have complicated histories could benefit from you as well. Now, um, I, we talked a lot about direct primary care, because that will allow you to get some of the needs that you have made. But I'll bring it back to what do you do after you decide
Mhm.
this is not a good fit? And we've heard ghost, we've heard you're going to have to get your medical records. So they're going to know you leaving at some point. But what I will say, I'll add to this, is if you've had a long-standing good relationship with your doc, and one thing happens with their staff, perhaps communicate that. I'll never forget, I went to work sick one day.
Mhm.
This was before COVID, and I was writing questions down, and a woman came back to me. She said, "You don't think da 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 da," and it was something that I didn't even hadn't thought about. And I said, "Why would you say that?" And she told me she said something, and I didn't address it. And I said, "Did you notice that I was writing my questions down that day because I couldn't talk?" And she had noticed it. I didn't know what she was talking about, but she had noticed that I was sick and I was just trying to write scripts. So sometimes there can be some genuine miscommunication. And if
Mhm.
that person has done right by you for a while, and you have one hiccup, have a conversation with them. Now
Mhm.
there is some real disrespectful things that have happened, but if it's been one time, or if you have concerns about their staff, have some conversations if you think that's a good doc. Because one thing I'll tell you is all docs are not created equal, and they are not. They're
Mhm.
not created equal, and so you can ditch a really good doc, and then you can discover how good the doc really is when you go doctor shopping. It's kind of like them talking about there's pee in the dating pool. Don't ditch a good man and then discover the dating pool sucks. so so I will do that. In our man, our time has gone. Tell us some additional reasons why you should leave and how you should approach leaving. And as we're wrapping up, because we're almost out of time, family, and we have had great conversation about strategies to get your needs met via direct primary care, via HSA, those kinds of things. Concierge medicine, something we didn't talk about,
Mhm.
but what are some other reasons to decide to leave? And then how do you do this strategically so that you don't get blackballed in medicine, so to speak, that there is nothing that shows up in your chart that you don't want to show up there?
Hmm.
And hopefully that wouldn't happen. But
Now
what are
that's
some
good.
things?
One of the things is, yeah,
Go
Dr.
ahead,
Rhonda,
Dr.
one of the things I would say is be respectful, because there's nothing worse than, being nasty. And so if it's just not a good experience, it's not where you want to be, then that's fine. And you can either call that office and say, "Hey, I'm leaving," or you could just send the medical records request, and then they'll send your records, and that's it. If you are at a visit and you feel like things are off, or whatever, and you try to have a conversation with your doctor, and they still seem like they're not here for it, they're not listening. We're people. We're all people at the end of the day. And so if it seems like you may have to grab their attention, "Hey, my concern is I feel like maybe you're not listening to me, or I said this or whatever," you just come out and say it. Approach them how you need to approach them. Be honest about it. It feels like you didn't get it. It's okay. And And I would say then that's when you should go ahead and start looking for some things could be in your chart when you do go somewhere else. And then if I see in there, okay, they had a shouting match with the doctor, people they look at that,
Dr. Booth, I'm hearing every other word that you say.
and that's those are the main. Oh yeah, I think it looks like everyone's breaking
Okay,
up.
I can hear you now. Anyone want to add to what she said?
Yeah, one of the things that you want to make sure that you do, though, so it's not your word against someone else's, is that you report it. Follow the proper channels to report, listing your reasons, giving your narrative of what took place. And again, going back to the trust relationship, if you go in cussing and fussing, doctors are human, and this is a professional situation. If the doctor chooses you because you're not addressing them properly, that's not the doctor with the attitude. That's you going there with your mind right. And if you want respect, you need to act in a respectful. Make sure you're doing everything that you're supposed to do, and make sure that you document and you actually have a witness of what happened, so that it won't seem like it's just you. Because if you leave the narrative up to someone else, it might not work out in your favor. And the last thing you want to do is be seen as doctor shopping, drug seeking.
Great points, great points. Ellis?
Mhm.
I would say, in keeping our relationship theme that we've kind of set for this show, typically when you're in a relationship, you say, it's not you, it's me. Well, in this relationship, you want to make sure you say, it's not me, it's you. And by doing that, that means you've done everything that you needed to do that you could do to maintain this relationship. Okay. And so that's, as Dr. Booth said earlier, the points that are put up there: being prepared, doing, doing your follow up, being adherent to your medication, even if it's causing side effects. You can go back and have a conversation, but you can't just stop taking the medication. Go back in 45 days. So I stopped taking it. So, because what they're going to write down is patient's not adherent to the medication, right? That's what they're going to write down, even though it could be for a number of reasons. It could be for the side effects. But do what you need to do. So when you get, so if you do have to end that relationship, you could say, "It's not me, it's you."
And yes, great points. And I love going back to what Dr. Griggs said to report your grievance if there is something that is egregious that has happened. Um, go ahead and have there be some kind of documented chronicling of that event that happened, so that you have that. For some of the most egregious things, people have been known to report, to state medical boards. That is, that's not for the, well, I waited for 45 extra minutes, but that is for the more egregious things. Someone, um, used a racial slur, they did not do something that needed to be done that caused you harm in some way, those types of things. But you do have recourse to deal with that. I will just tell you, as we are wrapping up, I'll go one more round of two things that should cause you to take pause and consider a different doc. What are those two things from each of you?
I'll go. One of the things I'll say is, like he said, trust your gut. So if you feel like something is just not right here, something is off, and I feel like they're not taking my concerns seriously, or they're not listening to me, that sort of thing. And then the other part goes back to your needs. It truly is. Are your needs, your medical needs, being met? And if you feel like these are the things that I'm looking for, and these things are not being done, then it may be time to go ahead and start looking for someone else.
Mm, hmm. I
I,
like it.
I love it. I love to trust your gut because there is, and people don't recognize it. We don't have time to kind of talk about, but there is a connection between your head and your gut, right? There is a connection there, and so if your gut is telling you one thing and you let your head talk yourself out of that, then you go back later on and say, "Oh, I knew something," and
Mm-hmm.
we've all experienced that before. You're not
Hmm.
listening. You're not listening to yourself. So trust that and trust that. And people can say, and people that are religious say that's God talking to them. However, you want to put a label on it, trust that feeling because that is the one that's going to lead you out of harm's way most of the time. The other thing I would say is if that person is very dismissive of your real complaints. And so if you're coming in and you're coming in there and you're only talking about what you wrote on that line that says reason for your visit, and that's the only thing you're discussing, and they're being dismissive of that, and then just say, oh no, that's not that bad. And they write you something that they feel like that you didn't talk about. Black women in particular, you might come in with some real complaints about that's connected to your heart, and they say, "Oh, that's just stress," and they write you something for anxiety, or they say you're not nothing as bad, and you really have a heart condition. That's something those are red flags that happen, and so so keep checking with your spots and do your research. The last thing I would say is this: there is a lot of information on credible sites like BlackDoctor.org. That's one of them where you can learn about conditions, you can learn about symptomologies and things like that. So the more knowledge you have, real knowledge, not Dr. Google's knowledge, but real knowledge that you have, walking into that, the more literate you sound to the doctor, the better that relationship is going to be because they're going to say, "Oh, this person has been engaged in learning about what's going on," so they're not just coming here and saying, tell me what I need to do," and I've got to do that. I've got to assess it and do that in 12 minutes. But if I walk in and I say, "Hey, doc, you know what? I'm doing this and this. What have you taken?" "Well, I took this many milligrams, that many milligrams. It didn't really work." You could tell them when it began, how long it's been going for, what you've been able to do. The more information you can give them, the better they are equipped not only to be able to listen because now you've eliminated some of that decision making that they've got to do in that short amount of time, and you become a patient that they say, okay, what I'm going to engage more, just like a relationship. The more somebody gives, the more you be like, you know what, I need to step my game up, and then now it becomes a two-way street instead of that one-way street.
Absolutely. I love it. And I think for me, I want someone who values and respects my time. And so, like I said, I did give the doc one more chance after that 2 hour wait. But that second time, I was out of there. I was gone. Even though I loved him, to pieces, a phenomenal guy. And I will say I ghosted him. But when I saw him in the streets, I said, I stopped coming to you because I could not stay in that office for 2 hours. He was like, well, call me when you get there. And I was like, I'm happy where I am. I didn't go back. But, as a physician, I did have access to his, I had relationship and
Mm-hmm.
I could have texted him, but I try not to play the doctor card. But he needed to hear that because that is the experience of his patients as well. And for me,
Mm-hmm.
another deal breaker is feeling like I am not heard and I'm being rushed while I'm trying to talk to you. Someone in our comments said, particularly cancer patients feel not seen, not heard when the docs are typing in their
Mm.
typing and not making eye contact. Those weren't her words. That was my interpretation. One thing I will tell patients sometimes is that is really important. Let me put that into your chart so I don't forget it. I think we've heard a number of people say that the time that we have is concise and we only have 15 minutes or 30 minutes or whatever. And there are certain things that if I don't put it in there, I'll forget. But I think you're saying something different,
Mhm.
perhaps. And I remember having a patient tell me that the doctor I had replaced, if they saw them at a grocery store, would not know who they were because from the time they walked into the office until they left, the doctor was typing, didn't look down. He said, she told me he wouldn't know the color of my eyes and he would not recognize me if he saw me because he never looked at me. He was busy typing and getting my prescriptions ready. And so she was pleased that I was actually making eye contact. Now, I, as a psychiatrist, make eye contact for various reasons. I want to know when I've hit a nerve that makes you uncomfortable. I want to know if you are self soothing. There's a whole lot that goes into those nonverbal cues that you're giving off that I need to know. So for me, it's a no brainer that I'm going to be making eye contact with you. If that is something that is concerning to you, I would say, um, perhaps you want to articulate that and see if that brings about change. Because I don't know why they're doing it and I don't want to make excuses for anyone, but what I will say is thank you all for tuning in. And Dr. Griggs, I was giving them just a couple of options to say of why you should consider leaving the doc. We are we are at the end of the hour, so Dr. Griggs, if you would make it brief and share with them a couple of reasons for why they should consider leaving, and when it's time to say it's time. Dr. Griggs, are you there?
I think he might be frozen.
All right.
He was having some
Well,
connection issues.
family, I just want to thank you for tuning in. Dr. Booth, you always bring it. I hate that I was having to interrupt you so that I could move it along, but you bring it, bring it, bring it. Family, go out there and look up direct primary care. Dr. Booth, tell them how to find you, even though you're licensed
Oh,
in Georgia.
sure. You can find me on. Yeah, absolutely. I'm licensed in Georgia and in South Carolina. You can find me on all social media at Dr. Ashley. That's an LIE, A Booth MD. So all social media: Facebook, YouTube, Instagram, Dr. Ashley A Booth MD. Thanks again for having me, Dr. Rhonda.
All right, my pleasure. And Ellis, we know how to find you. Dr. Booth, Ellis, Dr. Griggs, we are so thrilled that you joined us today for I'm Not Crazy, but I'm tired of you not respecting my time. I'm not crazy, but you are disrespecting me and I need my time. I'm like Auntie Maxine, I'm reclaiming my time. Give me my time. Yes. Family, I thank you. I appreciate you every week for tuning in. Same time, same place on blackdoctor.org on Thursdays, 11 a.m. Central Standard Time, 12 p.m. Eastern Time. Keep coming, keep coming, keep coming. And you know somebody who needs to hear this. Share it with them so they can have access to this information as well. I appreciate you. Bye bye.